I'm going to talk to you about Tarlov cysts and back pain in women, an experience in the last 1,000 patients. In fact, I'm around 1,600 patients now that I've seen. And these are almost, 90-something% women, usually Caucasian women. And they get treated like shit. And they get subject to gender bias and dismissal, and neurosurgeons, orthopedic surgeons just say, these aren't symptomatic and you're mad, you've got no disc herniation, get on with life. And they go to pain anesthesia who've got nothing to block, so they get put on Neurontin and Tylenol 3s or gabapentin or that pregabalin. And then ultimately, if they wind up on fentanyl patches, there's nothing you can do for them. So I get sent these folks, and I work really hard to figure out what's wrong with them. Why do they have low back pain? And in a nutshell, 80% have pain from something else that people haven't found, usually in the pelvis, usually GYN or facet joint disease or SI joint disease or inflammatory sacroiliitis or something. And then 20% have symptoms from their Tarlov cyst. And of that group, I can treat 80%, which out of 1,000 patients leaves about 40 patients for surgery. Now, sadly, right now, there are a couple of guys in the US who are making a living out of operating on all 1,000 of these people, and patients are getting hurt, and they're coming back with their old pain, with new debt from paying for their surgery, and no better. In fact, frequently in diapers or worse off. So the reason I wrote this paper that's going to be published in Neuroradiology was to create a decision analysis pathway for these patients who suffer, and to let patients be aware of this. Paper is public access. I paid $7,000 or something to make sure anyone can download it. And I'm very happy that Wouter Shevnik, the great neurosurgeon at Cedars-Sinai, agreed to be a co-author and read the paper, agrees with what we've done here. So this makes it a kind of a consensus document. So I have conflicts, and they're not related to Tarlov cysts at all. They're areas of other spine intervention, Spinifex Medical, IZI, Cora, new MRI machine at Synaptive, etc. But none of these are related to Tarlov cysts. These were first described by Tarlov in McGill University doing sacral dissections in cadavers, and he described these dilatations of nerve root sleeves in 1931. And he said that they can be symptomatic. I published a paper, about 8 years ago, on 213 patients that had treated and followed for up to 10 years at Johns Hopkins, where I developed this technique in about 2004. And I did that with Don Long, who just passed away, a great, great spine surgeon, chair of neurosurgery there, lovely person. And Sudhir Kathuria, I did some of these cases as well. So we published this paper on our experience with long-term follow-up, showing that we could have a successful outcome in about 81.8% of patients. So it's a good, safe technique using 2 needles. And, I'll go through the details of that. So when I evaluate these patients, I look at simple things. Are they an inpatient or an outpatient? Do they walk in, self-mobile or using a walker or a wheelchair? Do they come alone or do they come with someone? Do they have someone in the world who cares about them, loves them? Somebody who will help them be optimistic about the future. Do they have back pain or back pain and leg pain? Do they have perineal pain, neck pain and arm pain? We get them to do a dermatome map. We look at their medications, we examine them, and we look at their imaging. When you look at age and gender and back pain, you have different phenomena. But overall, one of the main things is women get treated less seriously than men, are more likely to wind up in medications, more likely to have a bad outcome than men. Signing and dating a dermatome map is critical for the medical record of what's going on. This is a male dermatome map. The female one looks like a hobbit for some reason. It's dreadful. But just documenting where their pain is really important. It's often a challenge because they'll draw like an L5 dermatome, but they'll say, my pain's coming from my Tarlov cyst, because they've gone down that rabbit hole of terrible websites like Tarlov Talk on the internet, where they just, sadly, there are people who have attributed every pain in their life to their Tarlov cysts. Tarlov cysts can cause pain below where they are, but not above where they are. So when people talk about having pain everywhere, is like except their eyeballs, they're really hard to get well. So it's important to listen, but then focus and be discreet and exact about what you do. Back pain in women, 20% of female back pain or radicular pain is extraspinal. So you look for piriformis syndrome, cyclical sciatica from endometriosis on the iliolumbar plexus, ischial tuberosity, calcific tendinosis, uterine fibroids, ischial spine compression, and Tarlov cysts. Cyclical sciatica, never forget that. Endometriomas on the iliolumbar plexus. And in postmenopausal women, these fibromes become more painful. People who can't sit, this is a classic thing in Tarlov cyst patients. And if they haven't been to the websites and they come in and they say they can't sit, that's a really good indicator that the Tarlov cyst is a problem. But again, people who can't sit, look for these things I mentioned before. Look for adenomyosis, look for a failed back syndrome, or somebody who's had a discectomy or fusion is no better, and then consider a failed back. So when I wrote that paper in 213 patients, and 177 of these followed for 3 to 6 years, I made that freely available. I put it on the web, on our LinkedIn page, etc., and that really helped patients. We looked at 456 patients who were referred between 2003 and 2013. 90% were female, 10% were male. That included, people, the males, connective tissue disorders, Ehlers-Danlos, Marfan's, Loeys-Dietz, stretchy things that have dural ectasias, and sacral diverticula, meningeal diverticula. The congenital group have these underlying abnormalities. They have a higher incidence of spontaneous CSF leaks and low pressure intracranial states. The acquired group, I think, are a disease that occurs in the region of the arachnoid granulations on the exiting nerve root. So you want to exclude the congenital from the acquired. And when people in the community or elsewhere read MRIs, they call everything a Tarlov cyst. Then the patient does the googly thing, and then they get swamped by information saying their life is over, they're going to be destroyed, and you have to undo that. Many of the things that are called Tarlov cysts are actually these dural ectasias, large sacral or meningeal diverticula, dilated sacral canal, and then a lipoma of a filum terminale going into this big, expanded distal thecal sac with scalloped vertebral bodies, erosion of vertebra, and potentially fracture in that location because the bone is so thin. So if they have any trauma, then they can just fracture that. And sometimes these cysts breach through the anterior wall of the sacrum and they become a capacitant sac. So when the patient valsalvas fills with CSF, suddenly intracranially the patient has an intracranial hypotension, the brain sags down and sits on the floor, tonsils go into the foramen magnum, patient becomes acutely unwell. Then the CSF redistributes as that pressure is removed, and the patient feels better after half an hour or an hour. I've had a patient recently seize during one of these events and die. I've had patients ask for medical assisted suicide made because of the chronic pain of these kind of unfixable abnormalities. You look at these things and you think, unless there's reincarnation, what can be done? And it's an existential issue for these people. Here's another example of a dilated distal thecal sac with a meningeal diverticulum with adjacent bony remodeling This is not a Tarlov cyst. There's nothing that can be done about this. It communicates directly with the subarachnoid space. It will compress and flatten the S1 or 2 nerve roots. These kind of big, chronic, congenital cysts are unfortunately untreatable. This poor kid, this is the cyst here, presacral cyst, compressing the urinary bladder. This is a patient with Loeys-Dietz syndrome. So we established 3 groups: narrow neck cysts on MRI treated by fibrin, ones that we could not determine the neck diameter, in which we did CT myelograms, wide-necked, which we referred for surgery. They grow, if they're Tarlov cysts, this is a Tarlov cyst, small, narrow neck cyst, grows incredibly slowly over time. Incredibly slowly. So over the years, 5, 6 years, you'll see 1 millimeter or 2 of growth. We do these procedures with conscious sedation, with IV fluids, with EKG and pulse oximetry, with fentanyl and Versed, patient prone, and CT fluoroscopy with sterile technique. There are multiple different techniques I can use. There's a single needle technique. It hurts. Bilateral approach, the coaxial approach, the 2 needle approach, and the transcytic notch approach to anterior cysts. This is a big Tarlov cyst with bony erosion. 2 needles go in, 1 deep, 1 superficial. Take out both stylets, aspirate, see if that CSF fluid level stays stable. If it does, great, you can treat it. If it doesn't, it's actually got a wide neck communication with the subarachnoid space, and you don't treat it. Then you inject the fibrin glue, Tacil made by Baxter, and you're done. Okay, and what happens? Okay, so here's a patient. Here's the initial cyst. Look at the flattened S3 nerve root here, really flattened, ribbon-like. Okay, here's the cyst. Then after treatment, let me back up. What I did here was I wanted to be sure. So I did facet blocks first because the patient had facet degenerative change. They did nothing for her pain. Having excluded everything else, I then used the 2 needle technique to treat the cyst. I used 2 20-gauge needles. Usually I use 18-gauge needles, 18-gauge spinal, regular spinal needles, 3.5 inch long needles. Into the cyst, aspirate, empty the cyst, and then wait and see if I can develop a stable air fluid level. And then I injected the fibrin glue here. So initial image, and you see the ribbon-like nerve compressed by the cyst. Follow up at 6 months, that nerve has now re-expanded and is circular, and the cyst has shrunk. So before and after, okay? Nerve before and after, and they get better. Now this lady, I have 13-year follow-up on her or something now. It's crazy. And we published her a few years ago. But this lady presented with labial and perirectal pain. These patients will have pain in places that you don't normally have to talk to patients about. I excluded everything else. And 2012, sorry, it's 11-year follow-up. 2012, here's her Tarlov cyst. She has 2 of them. The pain was on the left. I treated only the left. She came back in 2018. You could see that it was shrinking, that the wall was thickening. She came back in 2023. It's gone, and her pain is gone. So the beauty of staying in one place, having one job, is that you can get longitudinal follow-up on people, right? So 2012, 2013, shrinking, 2023, altogether gone after fibrin glue injection. It was interesting. The metrics of the BMJ case are interesting. I published it as a freely accessible open web paper. And since March 2019, when we published that, there have been 30,000 reads, 30,000 reads of the full paper. It's been downloaded nearly 19,000 times. So the technique works. And we learned in the first 213 people that they were sustained good results. I'm proud of having developed this. And the other things I'm going to show you now are about how to manage these patients. So, first thing, review where their pain is, dermatome map, register where their pain is documented, then look at their images. When you look at their images, look at the localizer images, identify everything, look for cavitary lung lesions, look for stones in the gallbladder, look for angiomyolipomas of the kidney. Most importantly, look in the pelvis, look for fibroids compressing the bladder and the presacral space. Look for presacral masses. Fibroids in particular can be massive, and the ultrasound may be massively positive, but the family practitioner may just say, oh, that's okay, and not realize how big these fibroids are and how much they compress the neurovascular bundle. Okay, so look for all that stuff, because the patient may have back pain and leg pain, but it's actually coming from the pelvis. Look for sacroiliac joint disease, asymmetric here, more on the left than the right. And if somebody is on anti-TNF drugs, always look for evidence of infection and psoas abscess. This patient was told she had a Tarlov cyst. Clearly it's not. And it turned out to be malignant degeneration of a schwannoma. She had this resected. She went on to get pregnant and has a baby. I think that's a win for us. Look at this asymmetry of the piriformis muscle on the left via the right. I treated this with a Botox injection, not her Tarlov cyst. Look at this multilobulated left adnexal cystic lesion, a compression of the neurovascular bundle. This lady thought she had Tarlov cysts. She didn't. She needed to see a GYN. Endometriosis, very difficult diagnosis. Here's a little endometrioma here. Here's another one here. If men got this, we'd have better diagnostic tools for this. It's shocking how bad we are at diagnosing endometriosis. It's still largely a laparoscopic diagnosis. But in this lady, it's not her Tarlov cyst that's causing her radicular pain. Her pain was cyclical as a result of the endometriomas. And then they can have laparoscopic surgery to remove their endometriomas. This case really upsets me. Okay, this really friggin' pisses me off. This lady has all the money in the world, and I mean billions. She comes along, referred by a friend who had helped, and she's told she has a Tarlov cyst and has got to see me. She'd been seeing a Gucci pain doctor in our Yorkville area here of town, which is the most expensive real estate in Toronto. She'd had epidural steroids, multiple rounds of ketamine infections, facet blocks and medial facet branch blocks and ablations, epidural steroids, SI joint injections, more ketamine, and then pie and pain injections and foraminal steroids. And she was on a ton of meds. She was on gabapentin for night sweats for menopause. It was really, really bad. I looked at her MRI and I realized she had an abnormal looking uterus. Now, I'm not a GYN imaging person, so I got my body imagers to look at this, and they said, this is probably adenomyosis. And she's got a cyst in her right adnexa. And she's got neuroforaminal narrowing at L5S1. Oh, that bit was me. So, we dealt with that. And we had her see the best GYN in town, the wife of one of my colleagues. She's going to have a hysterectomy. And when all that's done, I think we'll have a different patient in front of us. But people get so mismanaged and they fall into the trap of the business of pain anesthesia. Why do these things happen? Well, we had fun. We actually dissected the sacrums with operating microscopes at the University of Geneva with Jean Fassel in the lab there and Bojan Stimic. And then my student, Marina Jostis, did these beautiful illustrations where she drew all this. And you see the arachnoid granulation relating to the vein at the junction of the perineurium and dorsal root ganglion. This is where the cysts occur. Arachnoid granulations increase in number as you go from brain to sacrum. Some of them go straight into the epidural fat. Some of them go into veins. They're remarkably complex. It's fascinating stuff. Tends to be ignored less now with CSF leak being a big business. But this is the region in which Tarlov cysts occur. I wasn't the first to figure this out. It had previously been described in 1957 by these folks from Sweden. And it's kind of reassuring that I wasn't mad and too over focused on this. I studied our patients genetically. That wasn't really that useful. Apparently, there is a gene relationship with CSF leaks, but there isn't really a definitive gene that I can say for Tarlov cysts. You look at the incidence of them, and it varies from country to country. So there is some underlying genetic predisposition. The Polish get a lot of them, 7.6%. Some of this depends on whether the MRI was performed of the lumbar spine or truly of the sacrum. And when you do pure sacral MRIs, you see more of them. Makes sense. The symptoms of Tarlov cysts, lumbosacral pain, urinary issues, bowel bladder dysfunction, sexual dysfunction, low back pain, lots of things here that interventional neuroradiologists don't want to be talking to people about. The neurological investigation of them, you can pick up sural nerve conducting abnormalities, small nerve issues, different reflexes can be lost. Reflexes I've no intention of checking, by the way, because you'll lose your license. But so there, it's an interesting area. Now, how is open surgery versus our approach of the two needle technique? Well, the outcomes from open surgery are pretty awful. About 20% of patients have a significant problem, from sexual dysfunction to transient sciatica to wound infection and other major complications. 5% have major CSF leaks, and the number of days in hospital are quite extensive, with a significant number having to have redo surgeries and a risk of surgical site infection. You compare that to fibrin sealant, and the results are very different. The types of complications that occur with fibrin sealant and an image-guided procedure are, a very rare incidence of CSF leak. I've only had one patient out of over 1,000 that I think might have had one. There are 3% in the literature, but I don't understand that. Transient sciatica, I can decrease that by putting some Marcaine, a small amount, 0.5 cc's of 0.5% Marcaine in the Tarlov cyst itself, and then putting in the fibrin. A tiny incidence, 1% of bowel and bladder issues, very rare allergic reactions to sealant. Compare that to surgery, where there's a 9% incidence of CSF leaks, 17% incidence of sciatica, 11% incidence of sexual dysfunction, 5% incidence of wound infection, and 18% incidence of other things, including venous bleeding, seromas, erythema, and prostatitis, etc. So if you compare more discreetly, yes, the number is 83% complication rate for both, but the fibrin ones are all minor. The surgical 17 or 20% are major. So I think it's pretty clear that as a first step, one would have fibrin. So how do you analyze these things? Well, patient comes along, symptoms match, dermatome map, listen to what they're saying, rule out the fibroids, the endometriosis, facet joint disease, sacroiliac joint disease, everything else. Dedicated lumbar spine MRI. Then, if you're uncertain, just put a little needle in the cyst and put in some lidocaine and see if their symptoms go away. If no, the cyst is not the cause. If yes, go on to treatment. If the cyst is wide-necked, you can't treat, refer to surgery. Maybe do myelography if you're uncertain. But basically, exclusion. Make sure that the last thing you treat is the Tarlov cyst. Make sure there's nothing else first. Do facet blocks, maybe do test lidocaine injections in the cysts. And only after all of these steps do you treat the Tarlov cyst. In summary, the prevalence of sacral Tarlov cysts have been estimated mainly on incidental findings. They've been overlooked as a cause of pain. They clearly can be symptomatic. Screening for them involves a multidisciplinary investigation. Pain associated with sitting is kind of pathognomonic, but that can also happen with facet disease and SI joint disease. Women are disproportionately affected and disproportionately dismissed. Dedicated sacral MRI really helps. And if you need to, do a diagnostic test with lidocaine and aspiration. If you have to treat them, follow them. You now own them. And look after them, talk to them. It's a very simple procedure, the 2-needle technique. The complex part is looking after them. Thank you.